And so in addition to Kees Kloff and Deborah Stinson, we have Nancy Johnson, our own member, who has done some research of her own to see what we as individuals can do to deal with these challenges.
And yay for Nancy too.
Yeah. She's been with us since the beginning. So as we, of Indivisible, as we look at, we'll start with Kees, I think. And as we look at Jefferson healthcare, some of us remember back to a time when we entered into an agreement with Providence on record keeping. And there was some provisions in there that would have tied us to them, and we were able to strike those and still use MyChart, basically. We were curious to know what other sorts of arrangements we might have with Catholic hospitals and what that means in terms of our care and the ERDs.
Well, thanks, Bruce, for this opportunity to address your questions, and thank you for having sent them to me ahead of time so that I could adequately think about them and explore the information. First of all, I want to assure you that my fellow commissioners, Mike Glenn and his leadership team, and all of the staff at Jefferson Healthcare are committed to being 100% independent as a provider of secular healthcare here in East Jefferson County. We've been so for decades, we are so now, and we are committed to being so into the future. Last week, I actually listened to the League of Women Voters Forum that was held in 2014, and it strengthened my conviction that this is an important issue. Then yesterday, I listened to the recording of your January meeting with the folks from Kitsap County and Save Secular Healthcare Washington, and I learned more about why we all should be increasingly concerned. So that was very educational, informative for me. It's quite obvious that the U.S. Conference of Catholic Bishops has gone the extra mile to make sure that they close the loopholes in arrangements that might allow for the offering of, quote, immoral procedures. First of all, I'd like to thank Mike Glenn as well for having offered some help in this brief presentation. And what I'd like to do is I'd like to go through all of your questions that you sent, and then talk a little bit about the serious challenges we face as a small rural healthcare system and ask for your support, and then open it up for questions. Does that sound like a reasonable approach?
Indeed, it does.
Great. Well, the first question was, when patients are given a choice for non-emergencies like hip surgery, is the question of secular versus non-secular considered by our providers? Patients always have the right to specify their preferences regarding non-emergent referrals, regardless of their reasons. Providers will naturally consider secular status if prompted, but it may not be in the front of their minds when needing to make a referral. It certainly wasn't when I was practicing medicine, but then again, there were fewer Catholic healthcare systems at that time. Providers invariably tend to refer to settings where they believe their patient will receive the best care, but there may be more than one such place. When you are a patient, please make your wishes known. Obviously, the more services we provide locally at Jefferson Healthcare, the better assurance we have that patients can stay here for care and that their wishes are carried out. But I'll speak more to that in a minute. The second question is, what is the current nature of Jefferson Healthcare's relationship with any of the Catholic hospital networks? Bruce mentioned our relationship with Providence. In order to better communicate with other hospital systems, we had to go with the most common locally used electronic record system, which is called Epic. It was way too expensive for us to contract directly with Epic, so we contracted with Providence Hospital. They support the service, but we own the medical records. Our Epic contract is due to be renegotiated this year with Tegria, a new technology company formed in 2020 by, guess who? Providence. We have no religious restrictions on how we use the system or ERD language in the existing EPIC agreement, or for that matter, in any of our other agreements or contracts. And we will continue to make sure that there are none in all of our new agreements. Although we had some telemedicine contracts before the pandemic, they have become even more critical in the past few years. We contract with Insight for telepsychiatry, Providence Swedish for telestroke, Radia for teleradiology, and Northwest Pathology for telepathology. This includes approximately 50 different providers, and we're currently negotiating for extended telemedicine services with Eagle Telemed, a physician-led for-profit Atlanta-based organization that, according to an email I got from them this morning, is, quote, not affiliated with any religious organization, end quote. Our providers refer to other hospitals based primarily on where they believe the patient can get the most clinically appropriate care. For cardiology, it's usually St. Michael's. For stroke care, it's Swedish, unless it's determined to be from a bleed, in which case it's Harborview, which is also obviously the place we send people with major trauma. Realistically, our hands are often tied, and Catholic hospital services are usually much more available than our providers and services in secular institutions, including places like the University of Washington. That said, we often do send patients to the University of Washington for specific purposes. The third question was, are specialists from St. Michael who provide services in Jefferson healthcare facilities, for instance, the cardiologist, bound to the St. Michael ERDs while they are here in Jefferson County? I don't think so, and neither does Mike Glenn, but he is confirming this for me. However, end-of-life services continue to be an option for patients with cardiac conditions if their care is here at Jefferson Healthcare, because they are under the care of their primary care provider, even though there might be a cardiologist involved in the case. Or they're under the care of the hospitalist if the patient needs to stay in the hospital here. The fourth question, if someone needed to be moved from our ER or elsewhere in the hospital, how does Jefferson Healthcare decide what facility they'll be moved to? Are there steps we can take to make sure we are taken somewhere that will honor our advance directives and living wills? The attending doctor, always with the consent from the patient, if that consent is possible, makes referral decisions. Care is managed by the doctors at the bedside. Jefferson Healthcare, as an organization, has no role in that decision. We have no restrictions or requirements regarding transport, but we obviously facilitate the transfer once it is made. There's a severe shortage of beds and staff regionally, especially obvious during this pandemic. We frequently have to make dozens of calls for every possible hospitalization just to find an appropriate bed for a medical emergency. The stress on our staff is enormous, and during my years in practice, I never had to deal with that problem. There was no epidemic that was overwhelming either staff or hospitals. I can imagine that secular versus non-secular care may not be on the top of the list of the concerns that the physician has at that time. However, I do think that Jefferson Healthcare doctors are mindful of secular wishes, but equally mindful of finding a place where the patient can get the care they need. Fifth question, what can we do to make sure that we preserve secular health care in East Jefferson County? At the League of Women Voters Forum in 2014, Mike Glenn described our commitment to secular health care, and Scott Bosch, the former CEO of the former Harrison Hospital, formerly, I think, in Bremerton, but now St. Michael's, said, quote, "If you aren't worried about the future of small rural hospitals, you should be," end quote. Unfortunately, that's even more true today than it was then. More than 200 rural hospitals have closed in the US since 2005, and more than 50 of those in the past year. Here in Washington, however, hospitals aren't closing as much as they are, quote, merging, end quote, or perhaps better said, selling out, and mostly to Catholic health service organizations. Enumclaw, Tukwila, Arlington, Monroe, Sedro-Woolley, and other communities have lost all of their local control. Under Mike Glenn's administrative leadership, we followed a strategy of growth and more services. There are two primary reasons for this. First is that our community desperately needs the care locally, and it is the best way to assure that our patients get the care they want and that their wishes are fulfilled. We are the only rural hospital clinic system in the state offering medical surgical abortion services. We're active supporters of the end-of-life care, including death with dignity prescriptions, and have even provided that service in the hospital, though many people prefer to die at home. We support terminal sedation with our home health and hospice care, and my mother benefited tremendously from that support when she died at home here in Port Townsend. We have added dental, dermatology, oncology, and cardiology services, just to mention a few of the needs of our community. The second reason for growth is to remain financially viable and independent. The greater array of services we can provide, the more diversified is our revenue stream, and the more we can benefit from economies of scale. Greater stability means less likelihood of needing to sell out to an outside, bigger system. So here are 5 things that all of us can do. Number 1, get a booster shot against the coronavirus if you haven't already done so. We need to end this pandemic, which has stretched the capacity of our hospital district, both financially and with staff burnout and shortages. Jefferson Healthcare has gone well beyond what most hospital systems do in our collaboration with the local health department, often without reimbursement. Yet we still have about 3 unvaccinated patients each day in hospital beds at Jefferson Healthcare. This can be avoided. Number 2, please be mindful of the fragility of the rural health ecosystem. Rising costs and shrinking reimbursements will stretch us even more in the near future. We are small and unique. Potential legislative solutions in Olympia for large system problems may have serious unintended negative consequences for small systems like ours, where profit margins are extremely slim. 2 that are hot topics currently are the nurse staffing bill, which would drive up costs, and the charity care revisions bill, which could drive down reimbursement. We live in a complicated, imperfect world, and sometimes we have to choose the lesser of 2 evils. Number 3, please use our local hospital system. Use it or lose it. Please get your care here whenever you can, since our survival depends primarily on revenue from the services we provide. Number 4, please participate in the master plan process that Jefferson Healthcare is launching later this month. There will be many opportunities for public input as we plan to replace a 1965 building that the city has mandated we must replace, improve space for our current providers, and add more space for additional service. And finally, number 5, please support the bond that we will need in order to fund at least part of our master plan. Some people think that the hospital district gets significant financial support from local property taxes. In fact, we get only about $500,000 per year from property taxes, and this is less than 0.4% of our operating budget. Olympic Medical Center in PA gets 2.2% of its operating budget from property taxes. Island Hospital in Anacortes, 5.5%, and Whidbey Health in Coopville, 5.9%, just to compare to other similar sized public hospital districts. Our tax revenue barely covers the cost of our special public hospital district administrative requirements and compliance needs. In addition, the public bidding process required costs us several $1 million per year. That's one reason we applied for and received special permission to go with a design build process for our master plan. And we're meeting this week with our designated architect, engineer, and contractors. Will we need to come to this community for a bond to help pay for the plan? Yes, and we hope you will all support that effort. And thanks for allowing me to make this presentation.
Thank you, Kees. Well done. Are there, maybe we could go with Deborah Stinson and talk a little bit about evacuations and what happens at a maybe a traffic accident or something like that. And then we could have questions for both of you. Okay. So Deborah, what happens? You're in an accident, you're not conscious, first responders show up.
That's right. Yeah. So again, like Kees, I want to thank you for giving us the opportunity to come and speak to you about this important topic. I also watched both sets of videos and understand the problem and share your concerns. And I did bring them forward to our leadership at the district. I think most of you realize I'm pretty new to the district. I was involved with them for 8 years when I was at the city, sitting in on the oversight board. But now that the annexation occurred and I get to sit on the inside, I'm learning a lot more. It is a very complex system. And I mean, I think it's great. Everybody says, you call 911, these people show up, the job gets done, and that's all there is to it. And it is a very complex and challenging system that I have utmost respect for, and I'm doing my best to learn as quickly as I can. Many of my peers, as the new Deborah I just talked about earlier when we were coming on board, she has years of experience in the fire service, actually boots on the ground, doing the job, and really understands it intuitively. I'm coming at it from more of a governance position. And so as my want in that situation, I always thank you for sharing the questions because I was able to speak to our chief, our assistant chiefs, our medical services officer, and it's been a great learning for me. So I'm going to try to keep the answers to the questions that you posed ahead of time, and I'd be happy to answer questions afterwards if I can, and those that I can't, I will willingly say I can't, and we'll have a method for you to get those answers as well. So following Kees's lead, I'll start with the questions that were specifically asked ahead of time. And again, thank you for that opportunity. So the first question was, really what does happen in an emergency situation like a car accident, and how do the first responders decide? Actually, before I get into this, I just want to kind of give you an overarching response to all of these things. And I can speak only for East Jefferson, obviously, but from working with many of the first responders, I think that these statements hold true for all the districts in the county. We treat and transport all patients without regard to their ability to pay. in accordance with our EMS protocols that are established by our medical program director and state laws. Okay, we all operate under those same protocols and laws. And the protocols, I'm saying, well, great, show me a specific protocols, and then I'll be able to display them here at the meeting. And the challenge we have is the protocols are written in such a way that they provide guidance, but they cannot be overly specific, because there are just so darn many variables that come into play with every situation. It's the situation itself has multiple variables, and then your options, weather plays a part, the bridges take a part, ferries, so there's no one flow chart that follows says, well, if I have this, they're going to do X, Y, and Z. That's just, we can't say that specifically. So I'm not trying to dodge. That's just the way this, I hope you understand the situation there. But the goal is always to provide the best possible patient care and as quickly as possible, because minutes and seconds matter. When you're calling 911, we know that, we get there a little too late, or we make a delay in making a call, your survivability is at risk, or the quality of life after survivability is at risk. So that is always the goal, is to provide the best possible patient care, but also as quickly and efficiently as possible. The other thing you should know is that we will always attempt to take the patient and or family wishes into account if they're there, if the patient is conscious or has a family member, an advocate there to speak for them. But sometimes feasibility does come into play, and we can talk about that a little bit. So those are kind of the overarching answers here. So, when we talk about responding, say, to like a car accident, it really depends on ambulance travel time and the closest appropriate facility for the type and the severity of injuries and the number of patients, frankly. For example, a minor injury, obviously here locally, we're always going to go to Jefferson Healthcare. If we have severe trauma patient, we know if we went to Jefferson Healthcare, they would just turn around and say, this patient needs to go to the trauma center. Rather than use up those precious seconds and minutes, we're going to go directly to the trauma center. And sometimes if it's a level 1 situation or requires a level 1 trauma center, we are actually going to work with our 911 system to dispatch medevac, which is the helicopters, right? Getting air support, because that is absolutely the quickest way to get you to that kind of a service. And that service for our region is Harborview. But sometimes if the weather's bad and they can't fly for some reason, or they're not available, they're busy off on other missions, then we would consider the closest appropriate facility by ground. And that may be St. Michael's or any other regional facility. So again, that decision chart doesn't have in it ERDs. It hasn't been a traditional thing that we need to consider, and we can talk about how that could be, how we might want to approach that moving forward. The next question talked about, well, what about my designated hospital is full? If I have stated a wish that I will only want to go to this one hospital, and you're en route and you find out that they're on diversion, that they cannot take patients, what happens? They will do that on occasion, often due to capacity or staffing issues. And it's not really common in larger facilities, or at least as Commissioner Kloff pointed out, it hasn't been traditionally, but recently it's happening more often than not. And in that case, we just simply have to decide to transport to the next best appropriate facility by ground or by air as available. Again, these are really dynamic, in the moment decisions that are having to be made. There was a question, we've talked a little bit about medevac and the helicopters, and some discussions about it, and wanted to know what more can I tell you. And The first thing is that we think it's important for people to contact the two medevac agencies for specific membership details. We're really not inclined to want to speak for them. And I believe your member, Nancy, has already done some research there. So hopefully she can share some of that with you. But I can tell you how we use them, and we only call them for the most severe emergencies. And each helicopter has different capabilities and locations. So we work again through our 911 system, dispatchers, because they have contacts to both of them. They'll call out to both of them. They say, we have a medic back, we have this situation, here are the details. And they respond. And we will make the decision really based on which one can get here first. Because again, when we're talking about heart attacks, strokes, major trauma after a car accident, those minutes and seconds matter. So unless, of course, if family is there or the patient is there and say, I absolutely only want to go with one or the other, that's a decision, but it might be a life or death decision at that point. If you say, I want to wait for the one that's going to be 15 minutes later, that just might not be feasible. So at this point, you have to keep that in mind, that we really have to do what's most expedient for the patient to get them the best possible care as quickly as possible. The other question was delays in ferry service. And does that make it necessary to use hospitals outside of Seattle? And the answer is, it is a factor. We do have a procedure in place where we contact the ferry terminal emergency number, and they can hold the ferry for us. Sometimes you'll wonder why you're not going somewhere when the ferry's loaded. That's why an ambulance is on the way. So they will hold for the ambulances, and they can actually increase their speed going across the water as well if it's a real dire situation. So they're very responsive and helpful to us in that way. But again, if it's a patient that has a real severe time-sensitive emergency, we really do try to get those medevacs over here. That's always our first call, but the ferry is plan B in lieu of driving around, because it can be a lot quicker. Or there are also other hospitals. Again, our regional hospitals are always a choice too. You have St. Michael's, we have the bridge to contend with there, but that is also an option. Let's see. And then finally, you asked if you had any steps that you could take to assure that you're transported to a facility that is not bound by the ERDs. And again, we want to state, we always attempt to incorporate the patient's or the family's wishes into the decision when feasible. But again, traditionally, the ERDs are not built into our policies. It doesn't mean that we wouldn't honor them if you're saying, in this situation, it doesn't matter which hospital we go to, if it's St. Michael's or Tacoma, you can have that discussion with your responders. But the destination determination really comes down again to where are they going to get the best possible care in the quickest time possible. So that's really what it is. I'd say as far as making sure you can communicate that, make sure your family is fully aware, your friends, they're not going to go through your wallet and find out which helicopter, which medevac service you're contracted with, or looking for a post form or anything like that, unless it's really obvious. They're there to get their job done. They're having to make a lot of decisions, split-second decisions, oftentimes, on taking care of your physical and emotional body and spirit. So you can't really count on, having a written thing found in your wallet to get you to where you want to go. So I think I'm going to leave the questions. Those are the questions you provided in ahead of time. And I think I'm just going to leave it there. I've been talking a lot, and I want to hear your questions and see if we've left anything that needs to be addressed.
Well, I'd like to respond first and then open it up for questions. First of all, thank you for your public service to these elective offices. And you're obviously dedicated to that. And, I know it doesn't come with big bucks or anything. It's just something you do because it needs to be done and you're the right people for those jobs. Thank you for that, for your service. Also, what is very clear from both responses is the best patient care is the highest priority. And I don't think we want to discount the quality of care at Catholic hospitals. I think it's very high. And we have, we use St. Michael and other hospitals, and they have wonderful care. We really are concerned about these certain situations that could come up. And then the other thing that making a quick decision in the moment, it could be a matter of life or death, and that's something for us to consider also is in any of our thoughts. And the thought of having these, I think that very likely Nancy will speak to designating another person to help with decisions. I'm not sure if that's on her radar. Yeah, okay. So I think that we will get to that. Are there any questions for Kees and Deborah about what they presented to us so far? I see Deborah Peterson has her hand up.
Yeah, I'm a little dim on what my membership in Airlift Northwest means to me, because they might not be the ones to transport me if I had an accident. And you mentioned that you do transport people with regardless of their ability to pay. And I believe that I heard at another presentation by fire district people that the fire district does what it can to recover costs when they have subsidized them. But could you explain that whole thing a little bit better?
Do my best. It's another one of those complex situations, but yes, we don't ever ask to see your insurance cards or, all of that ahead of time. But obviously we do need to cover our costs because you're the ones ultimately paying the bills, keeping the district functioning. And so the users of that system do need to be able to help cover some of those costs. And so we do, we use a billing system to help us with it because it is such a complex situation. And they will go out and they bill insurance first. And so generally insurance does not cover air flights. And so that's why you need to have insurance there because frankly, we don't get billed for medevac. Whereas we're actually on the ground providing the service. We're paying for the ambulances. More importantly, we're paying for the staff. It's usually 2 or 3 people in that bus every time it gets out on the road. So those are expenses that we incur as a district, and we have to get those reimbursed. And that's what we go after. And we do go through insurance, Medicare, Medicaid, whatever. And those pay us back on a sliding scale, obviously, but we do recoup some of those costs. But as far as air transport, that goes directly to the patient and their insurance company. And so therefore, if you're not covered by the service that transported you, they are going to send you a bill. And I'm not going to take it any further. I think Nancy's done some homework in this area. Again, I'm not going to speak for them. I know I have Airlift Northwest, but there is a new one in town. I think I'm going to subscribe to that one as well. I think it's good insurance, but as far as if they're going to try to cover each other's patients or something like that, I don't know how that's working right now, to be honest.
Thank you.
Mm-hmm.
I see Marilyn.
I didn't hear Kees talk about hospice care. Is that offered at Jefferson Healthcare?
Yes, it is. Yes, we provide hospice and home health and palliative care, all of that.
Okay. And if you're at someplace like St. Michael's, is it possible to be transferred back to Jefferson Healthcare for hospice care?
I definitely would think so. I don't see why that wouldn't be possible.
So
Yes,
that
and-
might be an option.
Absolutely.
It is, and I'll just interject there too. When we were discussing that, you're not a captive anyway. We can't kidnap you and force you to go. If you don't want to be transported once we get there, and you realize how bad you are, and you say, maybe I want to stay here and get me to palliative care, get me to comfort care, get me home. We'll do that. That's your wish. We're not going to kidnap you and take you somewhere you don't want to go. And the other thing is, if we take you like to St. Michael's, and you get down there and they do all they can for you, and then you get to that stage, again, you have every right to be transferred somewhere else. They can't hold you captive either. So, just saying.
Mike,
Yeah, this is for Kees. When the decision is made by, say, Jefferson Healthcare, that the patient should be transported, let's suppose it's for an airborne medevac, how is that decision made at Jefferson Healthcare?
Well, it's made by the attending physician.
Okay,
So if it's in the, well, doesn't matter if it's in the emergency room or if it's a hospitalized patient who might need a higher level of care. And so what they do is they basically call around and try to find out where that care can be provided, where is there a bed available. And that's been the challenge. In fact, the hospitals in Washington state have all pooled together and agreed to collaborate in essentially bed sharing, so that
Okay.
if there's an available bed, they'll take a patient, because they've all been struggling at maximum capacity with insufficient staffing.
did Jefferson ever find itself in a position of taking patients from other regions?
Yes, we have on several occasions taken patients from Olympic Medical Center,
All right,
for example. Yeah, so the answer is yes.
thank you, that's helpful.
I think I saw Pat
Yeah, thank you.
and John.
Kees, are there reproductive healthcare providers in Kitsap County? And do they have hospital privileges anywhere? Do they need hospital privileges? And are we getting patients here that would otherwise go to Kitsap County as a result for abortion services, for example?
I can't tell you where the patients come from. We provide those services for our own patients, I believe. And so my understanding is that you would have to become a patient of a provider here at Jefferson Healthcare. But I don't know the exact answer to that.
And John Collins, then I want to go to Nancy and give her a chance to weigh in on what she's found out. Go, John.
Okay, Kees, would you be able to elaborate any on what are the economic dynamics or other dynamics that is causing the hospital chain, the Catholic hospital chain, to be buying out other hospitals, some of which I think are nonprofits like Swedish and Providence? And are we immune from those same dynamics here?
I wish there were a vaccine against against financial instability. It's almost always primarily over finances, John. It's extremely difficult in our current healthcare system in this country, with the kind of reimbursement that there is for services, and the tremendous increase in costs recently. Well, we spend so much on healthcare in this country because it costs so much, and the system is just out of control. There are too many middle managers and for-profit entities and insurance companies that are that are basically driving the cost up. And the administrative overhead required to deal with all of these different insurance plans is just remarkable. I mean, it's just, and so a small healthcare entity just it finds it very, very difficult because there are no economies of scale. And that's one of the reasons why the private physician practices in this community eventually all went to Jefferson Healthcare, because it's just too expensive for a group of several private physicians to pay all of the overhead associated with the paperwork and administration, malpractice insurance. I mean, all of these things have just gone so high that it's primarily for the financial reasons. And that's why we've taken a very aggressive approach to expanding our services and expanding the size of the organization, not only because the community needs it, but because as I mentioned earlier, the more services we provide, the more services we can provide. And a good example of that, we sort of make a joke out of this at the local conferences, at the state conferences. People ask us, how can a small rural public hospital district afford to provide dental care? And we say we do that through our dermatology program. Because dermatology is a very procedure-based practice for which the reimbursement is much higher than it is for our primary care providers doing all of the work that they do. And therefore, that's a center that we have that actually provides some extra revenue that we can then use to subsidize services that clearly are not, that do not meet the bottom line. And that's one of those is dental.
So I'd like to go over to Nancy and give her a chance to tell us what she's learned.
Well, first of all, these are not all my books. This is a Zoom background. I'm going to tell you a few things that I found, and then I'd like for you, Kees, and Deborah to let me know if they're not right, because it seems like you kind of get a lot of answers. When I saw the last Zoom meeting, I was pretty, it definitely caught my attention, and I knew that I needed to do something myself to try to find out answers. My understanding, the first thing I did was to contact my provider's office. And the provider's office told me that they'll always ask if they can, if a referral is who you want it to be to. But that it really hadn't come up to their attention much, the idea of secular hospitals versus religious-backed hospitals. It seemed reasonable to me that I would want to be transferred to St. Michael's for heart issues, because it's like a level 1 trauma center for heart services and cardiac services. And then I would want to be transferred to Harborview for strokes, because they are a level 1 stroke center, whereas St. Michael's is not. They're like a level 2. However, I realized that there are the questions of, is there going to be a bed available either in ER to service you or in the ICU? And I'd had personal experience with that with my mother, who was being transferred to a hospital, and I was there listening to the EMS trying to figure out where to send her. She had been treated at UW Hospital. That's where she wanted to go. They didn't have beds available. She ended up going to Northwest Hospital at that time. And so it's like, it was kind of frustrating, because it seems like no matter what you do, it depends on availability in the hospitals.
That's right.
Yeah. The air transport services, I thought, yeah, that sounded like a great idea. I called the Airlift International or Airlift Transport and talked to the person who was probably customer service, and she gave me some really good information. I liked her a lot. So I would recommend that if you have any questions about air transport, just call and talk to somebody there. I went by email, I think, but I really got good service. And they had told me at the time that their services are strictly for emergency air transport and billing. And that they didn't make the decision on where to send you. It was based on what the provider or the hospital tells them they have found as places they can send you for the appropriate care.
So far, everything that you have said sounds correct to me.
Good, thank you. EMS, so I talked to somebody there. They suggested that in case you needed to be transported and you needed to go someplace else besides Jefferson Healthcare, again, it would be determined by what was available for you. They did say that you could note on your post form that you would prefer to be sent to a secular hospital. And whether that happens, you know, who knows, but it seemed that that was reasonable. Then they said to keep a copy of that post form on your refrigerator and to have one with you in case you're in a car accident. To tell you the truth, you know, whether they'd find it if you were in a car accident, who knows.
And you would have this post form filled out because?
You would have it filled out because you would want to say if you wanted to be resuscitated by EMS or the hospital, and whether you wanted artificial feeding or hydration. And I was kind of surprised. It actually, in a conversation with my physician, I decided to fill it out a little differently because that does not necessarily mean you're at the end of your life. It may just mean you had a heart attack and you could be revived.
Right.
And I hadn't really got that. So that was good because then I went and got a new post form and filled it out. And I'm going to say on it that I would prefer to be transported to a secular rather than a religious affiliated or owned hospital. Does that sound right, Deborah?
It sounds right. The challenge then again too, though, is we don't necessarily have a list of which hospitals which, you know, again, that's not necessarily in our EMS training, as this hospital is secular and this one is religious. So you might need to be a little more specific on that, because again, unless we actually start building in new protocols, then that's just not going to be possible again when they're trying to make these quick decisions.
Okay.
And Nancy, maybe we could attach to that form. I was just thinking about it because it's on my refrigerator.
I can't hear you, Deborah. Did you say something?
I did.
I think that was Debbie Steele.
Yeah, it was
Or
Debbie
Debbie.
Steele. With a very unstable connection. But anyway, I was saying maybe we
you're
could make
unstable.
maybe we could make a list of the hospitals that are secular and staple it onto that form that is hanging on my refrigerator, just so it would help with that. Just a thought.
That sounds like a good idea.
Yeah.
I mean, I've been told that, you know, you're young, you're healthy, you probably don't need a post form, but I don't agree with that. So I will have it on my refrigerator. Also, Debbie.
Well, and if you carry the file of life, that's usually what they look for, is that file of life, the little red thing that you can get at all the fire stations around the area. It's magnetic, sticks to the fridge.
Right.
But it's also small. If you got two of those, you could have one in your car where it could be on the dash or something where it might be more likely to be seen and recognized for what it is.
Okay.
What was that called?
File of life.
File.
It's a little red thing that, you can fold up your directives and put them in there.
So anyway, those are things that I investigated. I also personally was told that in my chart, I could submit the medical power of attorney and the living will, and that would help guide the hospital in the care that I wanted. I mean, that's kind of beside the secular versus.
Well,
religious.
it's important though, because my primary care physician at Jefferson Healthcare, I mean, I think he asks me every year, do you have your living will and do you have all of your papers up to date? So I think that's a standard part of our protocol for complete comprehensive care.
Yeah, and also your health care directive makes sure that situations haven't changed and that you don't have
That's
somebody on your as your durable power of attorney that isn't around anymore, or you don't think would fulfill your wishes.
Yep.
Because that can be an issue.
Yeah.
Yeah.
I think that that medical power of attorney came to mind earlier as somebody who would know that you preferred secular
Right.
healthcare.
Yeah.
And allowing that to making sure that that is one of the factors considered.
Yeah, we're going to meet with an attorney on Thursday and about these and another issue. And when we do, we'll definitely find out where we should indicate that, because it's important. So when it came right down to it, I was pretty frustrated at the idea that where I go dependent on the availability of a bed, but I understand. And that's all.
Well, when this pandemic does end, and it will, and coronavirus becomes endemic in this community, and it will, hopefully our hospital systems will be in a position where we'll be more easily able to transfer people where they would most like to go.
Right.
I see Deborah's hand up, and Marilyn and Joe.
Yes, maybe Kees can tell me what flavor of hospital is Harborview? Is that public or what?
Yes, it's a public hospital.
So it's a King County Public
Yes.
Hospital District?
That's correct.
Uh-huh. And what are I know they have a burn center and trauma. Are they known for other certain things?
Those are the main things that I'm aware of. And,
Uh-huh.
and I'm not quite sure if they are a pure public hospital district like Jefferson Healthcare is, because they do have some relationship and affiliations with the University of Washington. So it may be some kind of hybrid, but I don't know for sure.
Hey, Marilyn.
I have a question of both the speakers. Do you think we're being frivolous to be concerned about whether it's a secular hospital? Is that way down on the list?
Well, I'll be honest with you. When I first heard that I was being invited to come here, I did think it was a little bit way down the list. But then after I listened to that 2014 League of Women Voters presentation and the presentation given 2 months ago, it really woke me up to the fact that this is a serious concern, and it's a growing concern.
Yeah.
Now, what we can do about it is another question. And of course, I tend to focus on what we can do locally here to beef up our own system. Wouldn't it be great if we could provide all of those services that we needed right here in Jefferson County? So,
Or if
I
nothing
think some
ever
of the,
happened to us that you couldn't take care of at Jefferson Healthcare.
My other question is, will you please make it clear
Mm.
to the public why it's important for our hospital to be independent when you're asking for that bond?
yes, and we, at our board meeting this month, we will be looking very specifically at the design of a campaign that we will need to launch in order to successfully go to the community. And a big part of that will be the importance of staying financially stable and independent.
I'd like to speak to that, what we can do about it. That's really good to hear, both those things. What we can do about it has been something that's been on our minds. And after the 2014 meeting, I think that there was, and Deborah can fill this out, some effort made to make it clear on a hospital website, some certain things. And I know that the Attorney General, Bob Ferguson, is working on, just you should know before you go somewhere what to expect, and making explicit some of these things that you don't find out till you're in a bad situation. So those are simple and honest things, and just being upfront. It's kind of picking around at the edges of things, but it's necessary, and it will help more people be more aware of the issue. The fact is that more and more of the hospital beds are controlled by Catholic networks in this region, especially, and we need to have some way for people to get to the services that are legally available to them without having to travel great distances. Deborah, do you remember what that was, that they needed to put something on their websites?
Around the time that they organized that forum, the ACLU had hired somebody to work on the issue of Catholic hospital consolidation here. And they were putting out requests to all of the hospitals to post information about specific services on their websites so that people could know whether what kind of reproductive care was given and what happened to people at the end of life. And I remember trying to go and see all of those at a bunch of different hospitals, but I think that it was didn't work the way it was intended, and it is not easy to go to a hospital and simply easily find what their policies are. I think a lot of them are posted, but they are nebulously worded. For instance, it didn't achieve what it hoped to achieve.
Didn't also the person from the Department of Health say that they're the Department of Health website? I saw the presentation, but I couldn't see what was in the chat. But she gave the link to where you go in the Department of Health website that then lists all of the hospitals and their policies.
Well, I get messages from them every week from Save Health, Secular Healthcare Washington, and they have what they call a binder of information, and it may be in that binder, and I can look.
Huh. You mean the link to the public health, to the Department of Health website?
There's a link in the messages I get every week to their binder, and the binder, I would imagine, probably does. If she said they had that, there's probably links in there, and they're currently asking people for to give them information about Kitsap County and what kind of services are available. They're actually soliciting information now, but I'll go look for that.
I think I left Joe behind. Joe? You okay?
You're muted.
Sorry. You're getting at some of the questions is that there's a lot of I don't knows. But I'm finding it very difficult to discern what end of life measures the Catholic hospitals will do and what they won't do. And since our last meeting, I'm actually in a small aging group in town. Not that we're not all aging. But this has been a topic of conversation, and one of the members really got a fire lit under after she listened to the recording of the January meeting. And she called, well, almost everybody and their uncle, but lots of administrators at Catholic hospitals, asking them whether they would honor our end of life directives. And the answer was universally yes. The only thing that they won't do, this is what they were told, is death with dignity, because that is essentially assisted suicide. But that they appreciated advanced care directives that would say, you know, at what point would you want to stop efforts to continue your life, whether it's taking you off of life support, ventilators, whatever, at what stage, and that sort of thing. And that the doctors at the Catholic hospitals found it very valuable to have that information from the patient as they're making their own decisions about how to move forward. So I'm very confused. I figure in my own mind, I'm not sure whether this is correct, that death with dignity is something that, at least with my family and friends who know that that would be something that I would desire at a certain stage, could be honored by transferring me either home or someplace else. But could I, with other things, would they, for instance, at what I say is the stage at which I would want to be unplugged, will the Catholic hospitals honor that? So I don't know whether you know the answers, those of you who have researched this, but it seems those are the questions. They're not just my questions, but those are the questions from our group. And it kind of feeds into to the comment or the question of, is this kind of silly for this to be, you know, high on our priority list about where we go? And I'm not sure how to assess that question unless we have these answers. And some of you have said that we need the specific answers, but they're sure not there now, except that the hospital administrators are saying, yeah, we'll do what you want. And I don't know whether that's true.
And Secular Healthcare Washington has conflicting information, the information that conflicts with that, really.
Yeah.
Is that what you were going to speak to, Deborah?
Yeah,
In answer to that?
I think that a lot of those reassuring statements, I'm cynical about them. I think that they are trying to give you the answer you want to hear.
Mm-hmm.
I don't think they do everything except, just as any other hospital would. I think that I don't think we're being. Maybe we're not. The silliness factor. Are we being silly? Well, maybe to base everything on that would be silly, because you could die. But also, I don't think I've heard about hospice care too, that there are things that Catholic hospice won't do that others will. That there are Catholic hospice services that are just not the same. So I think more research is needed. Once again, not surprisingly. Nancy's had her hand up for a while. Deborah, were you going to speak directly to that?
No, I have another end of life procedure to talk about.
Okay, let's go to Nancy.
Well, first of all, I'd like to say that it really is an issue that not very many people are aware of. I mean, even even the hospitals, the doctor's offices, EMS, just, they just are going to need to think about this a little bit, and it sounds like they're going to. The other thing I'd like to say is that as far as hospice goes, I know that my mom was on Providence Hospice, and they did not tell her about the death with dignity. She knew about it, but they didn't tell her. And afterwards, I asked them, well, why didn't you discuss that with her? And they're like, oh no, we can't talk about that. The social worker said that. So I didn't appreciate that. That's all.
May I chime in just on that point? I spoke to my primary care physician too, whom I absolutely love, at Jefferson Healthcare, and he was oblivious to this issue. I could hardly believe it. And he's also a hospital administrator. And he said, well, in my experience, there's never been a problem. So
Well, let me say that
left me a little dumbfounded, frankly.
let me say that what he said, in his experience, it's never been a problem. That could be true.
Yeah. Oh, I think it is true.
So,
yeah, he was speaking honestly.
It's if you've practiced medicine for 10 years, for 15 years, for 20 years, and you've never had a situation where you referred a patient somewhere who didn't get their end of life wishes satisfied, then you would have to say it's never been a problem. In which case it sort of drops down in terms of your list of priorities of what to discuss with patients.
Nor had he heard of any problems.
And that may also be true.
I completely trust the
Yeah.
honesty of his statements. That's not where I'm coming from.
Mhm.
But it seems to me that the Jefferson Healthcare physicians need to be better educated about this issue and be able to provide more clear and cogent answers and responses to their patients who are asking these questions.
Since people are asking this question more often now than perhaps they have in the past, I think that your statement is a reasonable statement.
And I think it is incumbent on us to do more research here and to find some more solid answers so that when we raise it as an issue, we know where we're at. I think Secular Healthcare Washington is a one source, but definitely always with an activist group, you want to make sure they know where they're coming from. And also looking at what the ACLU has done, they're certainly solid in looking at legal things, and they're going to have examples related to any of the lawsuits that they brought or whatever. So unless there's something more, I think we could move on.
Bruce?
Yes, Debbie.
I'm going to say one more thing and then I'm going to stop, because I know we've gone on longer than expected. But I had someone tell me last week that they had found a doctor they really liked at Jefferson Healthcare and just seemed like such a great guy. And they brought up the question of dignity. And he said he would never do that. And so they were glad they asked, and they were sorry, but they went back and picked a different provider. But he was very clear that that just wasn't within his.
Yeah, and that's a doctor's choice.
And that is a doctor's choice.
That's right.
So I just wanted to let you know.
Yeah.
And we're seeing, I'm not sure where they stand, but there were going to be some changes to the death with dignity. I don't know if that bill, does anybody know?
No.
No, okay. So Deborah.
I wanted to bring up the related issue of nursing home care and the legal ability of anyone to voluntarily stop eating and drinking in order to end their life. I think that is a huge problem if you are in a Catholic facility. they won't allow you not to eat and drink. So this is not something for anybody here to answer, but it's also something to be aware of. And I don't know if you were in hospice care for Jefferson Healthcare, if there's any prohibition for, they're not watching whether you eat or not anyway.
Well, actually, that's the choice that my mother made. And she was heartily supported by Jefferson Healthcare, Home Health, and Hospice.
And that's good to know.
Deborah's mother also.
Oh.
Well, she wasn't at the time, but she just did it. You know, she found out from Compassionate Choices and did it. Yeah.
She was in hospice, but they didn't lead her there. Right.
That's
okay.
something that the Catholic hospice services would not allow. Is that what you're saying, Deborah?
I'm pretty darn sure. I've heard stories about that. You might, that would be a case where you would, if it was important to you, you want to be transferred to somewhere else.
All right. Well, we want to thank Kees and Deborah and Nancy for presenting today. And we'll be proceeding with committee reports in a minute, talk about Ukraine, etc. So Deborah, thank you so much. And Kees, for being so responsive. That's what we like in our elected officials. This is definitely a case of democracy in action, right? People with questions getting them answered. So thanks for being here. And
thank you.
And I'll just say too, if questions come up later that you think about in the middle of the night or something, like, oh, send an email, put it in writing, we can get you answers. So
yeah, please. And that holds for me too. And I appreciate your interest.
Thank you, everyone, again, for bringing this to our attention. Appreciate it.
You bet. And I think we'll start with Gina. Ukraine is on our minds. We had a demonstration last week. Our leadership team decided to go ahead and have that, sponsor that, and we pulled it together and got word out. And we got 75 people, and we got good coverage. Nice picture of Gina and Margaret Kapka in the PDN. So go ahead, Gina. Foreign Policy Committee.
Okay, yeah, Foreign Policy Committee, what I was asked to do today was maybe not give a whole rundown of everything, which probably you guys have already been paying attention to. So if Bruce, if you could let me share the screen.
I think I've given you permission.
Okay. Let's see if this works. Okay, actually I typed this out yesterday and it's already out of date. Because you may know that Biden today okayed the banning importation of Russian oil, which the legislators had been, particularly on the left and the right, had been pushing for. There is another funding bill, the big omnibus bill, I think they call it, that they expect to attach $10 billion in humanitarian, military, and economic support for Ukraine. Although I guess there are some conservatives at last time this was discussed that were demanding a vote on defunding the vaccine mandate. So that might be something we could bring up to our legislators, although I'm sure that they're all in favor of this anyway. The other thing I was asked to come up with was what we can do about it, aside from go stand at Sims Way and wear blue and yellow. And so I looked at some of the lists of various institutions that are helping out in Ukraine. And this is the list. It's not a full list. I found a number of different ones. So I thought I'd quickly go through them.
Could we not go through them one at a time?
Yeah.
We're pretty far over time now.
Right, pretty much. Well, I was going to
maybe Debbie can send them out.
Well, I was going to see if I could maybe stick this in the chat so people could copy it off of there. But I did put them into several categories. Some of the big ones that we all know about, Doctors Without Borders is a favorite of mine. One that's trending is the World Central Kitchen, where you've got chefs going out and showing up on the border and feeding refugees.
Gina, if you send this to me, I'll make sure everybody gets it. I'll do a blast because this is great. Thank you.
Okay, well, a couple of them I wanted to point out, though, if I could, Bruce. Razom is a Ukrainian local organization. These are less known, but have been vetted by various Washington Post and other newspapers. Direct Relief. Now, Airbnb has a website where if you have a living space that you can volunteer to host someone in, that, you know, if you have a room or an apartment or something that you would be willing to donate the use of, that's what Airbnb is doing. I also found a couple of UK GoFundMes that are supporting independent journalism in Ukraine, which is important to get not only the news out to the world, but also to document some of the war crimes issues. Okay, so that's another aspect was if one could donate to military equipment. And there's some cryptocurrency stuff, and what there is looks kind of dodgy. And so that was a never mind. And fortunately, also today, of course, Poland said that they're giving us something like 29 MiGs that we can then get to Ukraine and maybe backfill them with some other aircraft. Anyway, so that's what I've got. And okay, so I'll get this emailed. Who am I emailing it to?
Debbie Steele.
Okay, and I'll also do a real quick cut and paste if I can. Oh, also next week, March 16th, is the Foreign Policy Team meeting, and if you would love to have some more people come to our meetings, anyway, email me and I'll send an agenda and a Zoom link. Okay, copy this and now, okay, so I will stop screen sharing and try to get this into the chat.
Thank you. And John Collins, anything on immigration action?
The Jefferson County Immigrant Rights Advocates, which is the immigrant arm of Indivisible, does advocacy like Indivisible does, but they also do direct service. And so right now we're focusing a lot on the Afghan evacuated family that we are hosting that arrived here almost 2 weeks ago. And we're already looking for a second home that we can get another one so they're not so lonely here as a Afghan family in a very non-Afghan culture. The one bill that I was disappointed in that the state legislature did not further, and that was to provide unemployment insurance for undocumented. That did not pass the House yet. There are still a lot of good measures in the budgets. There's two budgets, you know, of course, working their way through, and we won't know how that plays out until next week. But budget provisions that do enhance funding for affordable housing, which will affect, of course, immigrants as well as many others. So that's encouraging. As you know, the legislature has felt that they're fairly flush this year with tax revenue, and they're spending it, I think, in the right places. So that's in a brief it. Mm-hmm.
Thank you. And great to know that that family is here and sheltered. Mm-hmm. Marilyn?
I think I'll pass. Thursday is the last day of legislature, and there are a lot of bills having to do with climate action. And hopefully we'll find out more about that when we have our legislators visit us.
Thank you. And Annalee, you're muted. And
whoops. Happy to report that we just got a new Arizona phone team captain who, as it turns out, Debbie and I learned last night, was at the Ukraine rally at the Triangle, except because none of us had ever seen each other, we didn't know who it was. Anyway, we were happy about that. And John is on her team now. So.
Excellent. And I have to say, I've been overhearing some phone calls being made from this house, and they're going well.
Great.
Very well, so well organized, and Deborah's been digging in and having some really productive talks.
Thank you, Deborah.
Do we have any other? I don't see any other committees here. So with that, or anything else anybody just really needs to share at this moment?
I couldn't cut and paste the list of services. So email me and I'll send people a copy. I'll also send to Debbie, but I've gotten my email in there, if not the whole list.
Great, thank you. Anybody else for the good of the order here?
Thank you again to Kees and Deborah.
Yeah, really. Okay, well, thanks for being here.